Good afternoon, everyone. My name is Ann Wong, and I am with the Illinois Chapter American Academy of Pediatrics. And I thank you for joining us for today's webinar on meningococcal vaccines. Today, we are joined by Dr. Sarah Mbei from the Centers for Disease Control and Prevention. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded, and after the webinar, probably by end of business day or tomorrow, everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, a link to the recording of the webinar, and I think I already covered everything. Okay, and then if you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar, which is located on the right-hand side of your screen, and Dr. Mbei will answer them at the end of the presentation. I would now like to introduce Dr. Mbei. Dr. Sarah Mbei is a board-certified pediatrician who has worked at the Centers for Disease Control and Prevention since 2011. She currently serves as a medical epidemiologist in the Meningitis and Vaccine Preventable Diseases branch, where she is the CDC lead for the Advisory Committee on Immunization Practices Meningococcal Vaccines Work Group. She completed her medical and Master's of Public Health degrees from St. Louis University Pediatrics Residency at the Boston Combined Residency Program in Pediatrics through the Schools of Medicine at Harvard University and Boston University, and the Epidemic Intelligence Service Fellowship at CDC. Please join me in welcoming Dr. Mbei. Okay, I'm going to go ahead now and turn it over to you.
Great. Okay. Thank you so much for that introduction. It's really a pleasure to be speaking with you all today. I'm actually originally from Illinois. I grew up in the Peoria area, so it's nice to be joining my fellow Illinois colleagues today. Okay, so we'll move to the next slide. So I have no conflicts of interest to disclose. However, I will be discussing the unlabeled use of meningococcal vaccines. This, okay. Including the administration of MenB vaccines in certain persons above age 26 years of age, and the administration of MenACWI vaccine in certain persons aged greater than or equal to 56 years at increased risk for meningococcal disease. Okay, trying to advance the slides. What's happening? Well, is the slide advancing on your end?
It is not advancing.
Nuts. Huh.
I need to pull it up on my screen and then I can advance them.
Yeah, I can't seem to be advancing it the usual way on my end.
Okay, I'll go ahead and pull it up on my end. Sorry about that, everyone. Just give us one moment.
Okay, thank you so much. Okay, so we can go to the next slide. So the objectives of today's presentation is to describe the epidemiology of meningococcal disease in the United States and describe the current Advisory Committee on Immunization Practices recommendations for meningococcal vaccines. Next slide. Okay, so first I'll be giving an overview of meningococcal disease. So as you're all aware, meningococcal disease is a very serious infection. It can present as meningitis, a bloodstream infection, pneumonia, along with some other manifestations. And the signs and symptoms include fever, headache, stiff neck, confusion, rash, vomiting, and diarrhea. And it is transmitted person to person through close contact with respiratory secretions from patients or asymptomatic carriers. And despite adequate antibiotic use and ICU level care, we're still seeing high rates of morbidity and mortality due to this disease. About 10 to 20% of patients die even with appropriate treatment, and 11 to 19% of survivors have long-term health issues. Next slide. So Neisseria meningitidis is classified into serogroups based on its capsule. The capsule is the polysaccharide coating around the organism, and serogroups B, C, and Y are the primary causes of disease in the United States. And understanding the different serogroups is also important for understanding how the meningococcal vaccines work and their targets. So the two vaccines we have here in the US have completely different mechanisms of actions. They target different things. So the quadrivalent conjugate meningococcal vaccine, or MenACWY vaccine, works by targeting the polysaccharide capsule, and the recombinant serogroup B, or MenB vaccines, target the subcapsular proteins. Next slide. So in this figure, you can see the incidence of meningococcal disease in the United States over the past 20 years. And incidence has declined about tenfold in this time period, from 1.2 cases per 100,000 population to about 0.12 cases per 100,000 population in 2016. And these declines began prior to the introduction of MenACWY vaccine in 2005 and prior to the availability of MenB vaccines in 2014 and 2015. Next slide. And this figure shows the incidence of meningococcal disease by age group in the United States since 2010. And the first thing you can notice in this figure is that the incidence is actually highest in infants under the age of 1 year, followed by 1-year-olds, and kind of has this bimodal distribution such that as increases at the extreme ends of life, we have the highest rates of disease. But we can also see in the red box that adolescents also experience a bump in incidence of disease around the age of 16 years. Next slide. And if we look at just this adolescent age group in a little bit more detail and by serogroup, we can see that the majority of disease in adolescence is due to serogroup B, which is shown in the blue line. So on the x-axis is the age in years, so 11-year-olds to 26-year-olds. And on the y-axis, again, we have the incidence. And we can see that incidence is pretty low up until around 17 years of age. We see a increase in incidence around 18 to 20 years of age, and then declines again in terms of serogroup B incidence. And the incidence due to serogroup C, W, and Y, however, remain pretty low through this age group. Next slide. And part of this increase, or I guess I should say, it appears that college students have a higher incidence of meningococcal disease due to serogroup B compared to non-college students of the same age. So on the left-hand side, we see in this figure that the incidence of serogroup B disease in college students is about 3.5 fold higher than that observed in non-college students, which is shown in the orange line. And this, again, this incidence peaks around 18 to 20 years of age and follows and declines following that. And on the right-hand figure, we see serogroups C, W, and Y combined, and we can see that the incidence between college students and non-college students is pretty similar and is similarly low across this age group. Next slide. And another concern is the occurrence of outbreaks of serogroup B meningococcal disease on college campuses. We've seen 10 outbreaks since 2013 of serogroup B disease, and these outbreaks have ranged in size from 2 to 9 cases. We've seen them lasting from just a few days to stretching over many, many months, and affecting an undergraduate population size ranging from about 4,000 to 35,000. These have occurred at small liberal arts colleges all the way up to large state public universities. And at least in the last couple of years, a little over 30% of all serogroup B cases in college students were outbreak related. Next slide. And now I'll switch gears and give kind of a brief overview of the licensed and available meningococcal vaccine products, and we'll go into all of these in more detail in upcoming slides. But in summary, we have 4 available and licensed meningococcal vaccines in the US currently, 2 MenACWY vaccines and 2 MenB vaccines. And just of note, we do have 2 additional licensed vaccine products in the US, but they are no longer currently available, so you won't be coming across them, but just for you to be aware, the MenoImmune, which is a polysaccharide ACWY vaccine, and Menhibrix vaccine, which is a combined Hib and meningococcal serogroup C and Y vaccine, but again, these are no longer available here. Next slide. And just to give you a brief overview to start with of the current Advisory Committee on Immunization Practices, or ACIP, meningococcal vaccine recommendations in adolescents. For the MenACWY vaccine, ACIP recommends routine administration for all adolescents aged 11 to 18 years. And this is known as a recommendation category A because, again, it is routinely recommended for everybody in this group. In contrast, the MenB vaccine recommendation is that a MenB vaccine series may be administered to adolescents and young adults aged 16 to 23 years to provide short-term protection against most strains of serogroup B meningococcal disease. The preferred age for MenB vaccination is 16 to 18 years. And this is known as a recommendation category B because unlike MenACWY vaccine, where everyone is recommended to get it, for the MenB vaccine, it's an available vaccine and adolescents may be vaccinated based on clinical decision making. So that clinical decision making between the provider and the adolescent. Next slide. So in summary, meningococcal disease is a rare but serious infection. And although the incidence is low, college students have an increased risk of serogroup B meningococcal disease. And MenACWY and MenB vaccines are available for use in adolescents, though the recommendations differ. Next slide. Okay, so now we'll talk a little bit more about the serogroup ACWY meningococcal vaccines. So as I mentioned, there are 2 available MenACWY vaccines in the US, Menactra and Menveo. They're both conjugate vaccines that protect against those 4 serogroups. And Menactra is licensed in persons aged 9 months to 55 years, and Menveo is licensed in persons aged 2 months to 55 years. Next slide. And as I mentioned, the ACIP recommendation is for routine vaccination of all adolescents aged 11 to 18 years, with the first dose at age 11 or 12 years and the booster dose at age 16 years. And in terms of the catch-up recommendations for this vaccine, if the first dose is at age 13 to 15 years, the booster dose should be administered at age 16 through 18 years. But if the first dose is received after the age of 16 years, a booster dose is not needed unless the individual becomes at increased risk for meningococcal disease. Next slide. So in addition to adolescents, ACIP also recommends the routine vaccination for persons aged greater than or equal to 2 months of age at increased risk for meningococcal disease. And this includes people with certain underlying medical conditions, which I've listed below, as well as unvaccinated or undervaccinated first-year college students living in residence halls, military recruits, microbiologists, travelers to certain areas of the world, notably the meningitis belt of sub-Saharan Africa, and persons at risk during an outbreak of meningococcal disease due to these serogroups. Next slide. And in this figure, I'm showing the estimated coverage of MenACWY vaccine in the United States among 13 to 17-year-olds. So in the purple line is the coverage of greater than or at least 1 dose of MenACWY vaccine. And in the blue line is at least 2 doses of MenACWY vaccine in 17-year-olds. So what we can see here is that since the implementation, the first recommendation for MenACWY vaccine, the coverage in adolescents has steadily increased and is now at about 85% coverage. However, the two-dose coverage, the booster dose coverage in 17-year-olds is lagging behind still, and it's at about 40% as of last year. Next slide. And however, we've seen that this, the vaccine is effective. In terms of the overall effectiveness of this vaccine, it's at about 69% for any serogroup, but ranges from 51% to 77% effective for serogroups Y and C respectively. However, we do see some waning of immunity over time. So the vaccine effectiveness is 79% in the first year since vaccination, but over time wanes to about 61%. And this was part of the rationale for introducing the booster dose at age 16 years, knowing that the vaccine wanes over several years. That booster dose at age 16 years provides a boost in immunity during that period of increased risk, that older adolescent age group. Next slide. And in this slide, I'm showing you the changes in incidence over time. And what we're seeing is evidence for impact of this vaccine on incidence of disease due to serogroups A, C, W, and Y. And just to orient you a little bit to the slide, in the left-hand figure, we see the incidence of A, C, W, and Y by age on the x-axis from 11 to 29-year-olds, with incidence on the y-axis. And in the light green line, we see the incidence of serogroups A, C, W, and Y in the first several years since vaccine was introduced. The vaccine was introduced in 2005. So those initial 5 years after vaccination are shown in the light green line, and in the dark green line, we see the incidence from 2011 to 2015. So the more recent years after that coverage has increased a little bit. And so we see that there's been a decline in the incidence of ACWY vaccine over these two time periods. But on the other hand, for serogroup B, which is on the right-hand side, we're basically seeing very little change in the incidence of serogroup B vaccine during the same time period. So this is suggestive to us that, that the vaccine introduction has led to declines in incidence of serogroups of disease due to serogroups A, C, W, and Y in the United States. Okay, next slide. So in summary, all adolescents are recommended to receive MenACWY vaccine at age 11 to 12 years with a booster dose at age 16 years. MenACWY vaccine is effective, but the booster dose is needed due to waning immunity over time. Coverage with one dose of MenACWY vaccine is high. However, additional efforts are needed to improve coverage of the booster dose to protect older adolescents during the period of greatest risk. And we recommend that healthcare personnel use every opportunity to provide the booster dose when indicated, regardless of the vaccine brand used for the first dose. And the reduction in incidence of serogroups A, C, W, and Y in the United States in adolescents suggests impact of the MenACWY vaccine program. Next slide. So now we'll move into talking about serogroup B meningococcal vaccines and the recommendations. So we currently have two MenB vaccine products licensed in the United States, Trumemba and Bexsero. These are both protein-based vaccines that are licensed against serogroup B. And the licensed age group for both of these vaccines is 10 to 25-year-olds. Next slide. So as I mentioned, these have been recently licensed in the United States. Trumemba, which we abbreviate as MenB FHBP based on some of the components of the vaccine, was licensed in October 2014. And Bexsero, which we abbreviate as MenB 4C, was licensed in January 2015. And for both vaccines, this is a two-dose series in healthy adolescents. The MenB vaccine products are not interchangeable, and the same vaccine product must be used for each dose. Next slide. So again, to repeat the ACIP MenB vaccine recommendations for healthy adolescents is that a serogroup B meningococcal vaccine series may be administered to adolescents and young adults 16 to 23 years of age to provide short-term protection against most strains of serogroup B meningococcal disease with a preferred age of 16 to 18 years of age. Next slide. However, just similar to the MenACWY vaccine, there are additional vaccine recommendations in persons aged greater than or equal to 10 years of age who are at increased risk for meningococcal disease. This again includes persons with certain underlying medical conditions, microbiologists, and persons at risk during an outbreak of meningococcal disease due to serogroup B. Next slide. So I'll go through each of these vaccines in a little bit more detail. So the MenB FHBP vaccine, or Trumemba, in healthy adolescents, the dosing is a 2-dose series administered at 0 and 6 months. However, the recommendations are slightly different for persons at increased risk of meningococcal disease. So that group I showed on the last slide, including during outbreaks, is actually recommended as a 3-dose series administered at 0, 1 to 2, and 6 months to provide earlier protection and to maximize the short-term immunogenicity. Next slide. So for MenB4C or Bexsero, the dosing is the same both for healthy adolescents as well as persons at increased risk for meningococcal disease. And this is a 2-dose series administered at 0 and greater than or equal to 1 month. Next slide. So just to review some background or some information on these vaccines in terms of their safety, effectiveness, and duration of protection. Understanding some of this does provide a little bit of, I guess, improved understanding of why the vaccine recommendations differ between the two vaccines, MenACWY and MenB vaccines. So just in terms of, to start with the safety, for MenB vaccines, the rates of adverse events are pretty similar to those observed with other adolescent vaccines. So, so far, no major concerns there. We don't currently have effectiveness data available in the United States or for adolescents globally. However, MenB vaccine is being used in several countries in their infant program. So we do have some data from, infant use. In the UK, the 2-dose MenB4C or Bexsero effectiveness among UK infants was about 83% in the first year following vaccination. So pretty good effectiveness in this group. However, we are seeing evidence for waning of antibodies in adolescents as early as 1 to 2 years following completion of this series. So because it's a new vaccine, we don't exactly know the expected duration of protection, but we can at least see from the antibodies through the clinical trials and other studies that the antibodies appear to wane pretty quickly. Additionally, the evaluations that have been conducted to date show little to no impact of MenB vaccines on serogroup B carriage, suggesting that herd protection is unlikely. And just to expand on that a little bit, as I mentioned in the background, meningococcal, the organism is transmitted person to person and often, in most cases, transmitted through asymptomatic carriers. So if you have a vaccine that interrupts carriage, you can really protect a lot of people through herd immunity, but we haven't seen evidence for that for this vaccine as of yet. Next slide. So to further expand on this, I think probably a lot of you are wondering, why don't we have a routine recommendation in adolescents for the MenB vaccine like we do for MenACWY vaccine? And ACIP considered a number of factors when making this decision, partly due to the burden of disease. So the number of preventable cases and deaths through vaccination is low. So we're actually seeing about an average of 20 cases of serogroup B per year in college students, which is the group at greatest risk among adolescents, which is pretty low number of cases. Though of course every case is serious, and we wish none of them happen, but the burden is pretty low. And the number needed to vaccinate to prevent one death is estimated at about 1.6 to 2.8 million, depending on vaccination strategy. So in some situations, depending on the strategy, you would have to vaccinate up to almost 3 million adolescents to prevent one death of serogroup B disease. In addition, MenB vaccines are expected to cover a wide range of circulating MenB strains in the United States, but they will not prevent all cases. The MenB vaccine is strain specific. It doesn't protect against every single serogroup B strain. And finally, as I mentioned, it appears that there is limited duration of protection of MenB vaccines, and also the lack of evidence for vaccine impact on carriage may limit the ability to protect adolescents through the period of greatest risk. Next slide. But having said that, the MenB vaccines are available. They are available for adolescents, and can be administered in consultation with their healthcare provider. So it's important that there is awareness of these vaccines out there. But what we've seen so far is that there are currently gaps in awareness of MenB vaccines among both parents and providers. In some recent studies, evaluations, we've seen that 43% of parents of adolescents aged 16 to 19 years report being unaware of MenB vaccines, report being aware of MenB vaccines, and among these, 69% became aware through their child's healthcare provider. So it seems that the child's healthcare provider is an important source of information for those parents who were aware of the vaccine. However, only 70% of pediatricians and 21% of family practitioners report being very aware of MenB vaccines. We've also seen that uptake of MenB vaccines among adolescents and young adults is estimated to be low at this point. Coverage of at least one dose of MenB vaccine among 17-year-olds is estimated at about 15%. We don't actually know the uptake in college students specifically. However, a recent survey did show that only 2% of colleges specifically require MenB vaccine, and only 24% stock the vaccine. Next slide. So in summary, although MenB vaccines are not routinely recommended for all adolescents, providers, patients, and their parents should be aware of their availability. And among adolescents, the risk of serogroup B disease is greatest in college students, and thus the pre-college health visit provides an opportunity to discuss MenB vaccines with students and their parents. Next slide. Okay, thank you. That concludes my presentation, but I'd be happy to take some questions.
Okay, so thank you so much for the presentation. Just to remind everyone to please enter in their questions onto the right-hand side of the control panel. So the first question that I have is for the catch-up schedule of Men-ACWY, what if a patient received the first dose before 15 and now they are older than 18? Do they still get the second dose? If so, up to what age should we give that second dose?
Great, thank you for that question. So if somebody received, if I understood the question correctly, somebody received the first dose kind of on schedule, before, they weren't 16 or older by the time they got their first dose. However, they're now 18-year-olds and haven't, if they're and are asking about the second dose. So the recommendation is up through age 18 years of age. So if that adolescent is still 18 years of age, they should be vaccinated. Beyond that age, it's really only for persons who become at increased risk of meningococcal disease. That does include college freshmen living in residence halls. But if you're 19, 20, 21 years old, not going to college, not otherwise at increased risk, don't have those underlying medical conditions, et cetera, then it's not recommended.
Okay, so I think right now I don't see any questions coming in yet. People might be typing them up. I have one. It says, in regards to the MenB 2-dose series, what if they do not have the second dose of MenB in 6 months? Can they still get it at a later time, say 12 months later, or does the series need to be restarted?
Yeah, thank you for that question. So, There is no maximum, at this point, there is no maximum delay at which point you have to restart the series. So, and along those lines, we don't currently have any, booster dose recommendations for Men-B vaccines at this point. So if somebody, regardless of the vaccine, Bexsero or Trumemba, the most important thing is that those minimum intervals are not violated, that somebody didn't get the vaccine too early. Of course, these being adolescents, it's understandable that maybe, they don't come in at the exact time they're supposed to, but sticking to the schedule to the extent possible is what's recommended, but we don't have any maximum time periods at which they have to restart the schedule.
Okay, and then someone has a question. They said that their patient is 21 years old. She lives near a college campus and attends community college. She received her first dose of Menactra at age 15 years old. Does she qualify for Menactra now? Also, does she qualify for Men-B? We were unsure because she doesn't live in a residence hall setting. Otherwise, she is in good medical health condition with no comorbidities.
Okay, so just to repeat the question, make sure I understood it. So the patient is 15 years old, is that right?
She's 21 now, but when she
Okay,
was 15, she received the first dose of Menactra.
okay. And she is not a college student, is that right?
She attends community
She
college, but
attends.
so she does not live in a residence hall.
So the ACIP recommendation is specifically for college freshmen living in residence halls. So that is the group for which there is an ACIP recommendation. So I would say that's what she doesn't fall under that recommendation to get the vaccine. However, there may be other extenuating circumstances that you discuss with her, or that kind of thing. It's not that people are not allowed to get it, that you absolutely can't get it, but the ACIP recommendation is for college freshmen living in residence halls.
Okay. And then another question that we have is, are there increased incidences of side effects when giving Men-B and Menveo vaccines at the same time?
No, there have been some co-administration studies done to look at that, and there wasn't any issues during those trials. So for the ACIP recommendation, it's totally fine to give them at the same time. It's just recommended to give them in alternate sites if possible, so not in the same arm. And that was just based on expert opinion, just to reduce any likelihood of any adverse events, but there were none reported, or no significant concerns reported in the trials.
Okay. So for now, it looks like I'm not getting any questions. So if people are still having any questions, feel free to type them into that box. But I'm just going to quickly go over when people should expect to receive their continuing education forms and everything. So just to reiterate from the beginning, you'll be receiving a copy of your PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by end of business day tomorrow. And everyone has to complete their evaluation by September 13th, 2018. After this date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive a certificate of attendance and or continuing education credit. And then 2 weeks after that, so approximately by September 27th, you should receive your certificate. And that basically hopefully answers people's questions about anything concerning that. I'm not seeing any more questions right now, so hopefully that means that, okay, yeah, and then I think that is about it. Otherwise, do you have anything else to add at all, Dr. Mbei?
No, just thank you very much for your interest in the MenB vaccines. And yeah, again, if there's any questions, I'd be happy to respond to them.
Okay, great. I think that concludes our webinar for today then. I just wanted to thank everyone and especially Dr. Mbe for this presentation. I know that with, all of the multiple vaccines for meningococcal, things get kind of confusing. So thanks for clarifying everything for us and also giving us all that new information about stats and stuff. So thanks everyone, and hopefully everyone has a good afternoon.